To our next talk. The topic is about the evolving landscape of HPV-related head and neck cancers, presented by Dr. Michael Hwang from Memorial Sloan Kettering Center. Yeah, welcome. Thank you.
Okay, that's probably not. This is up to you. I'm going.
Okay. Hi, can you guys hear me? Okay, so hi everyone. First of all, I just want to thank the committee for organizing the symposium and inviting me here. This has been a very good experience so far. And I just want to thank everyone for attending this talk. My name is Michael Hwang. I am a head and neck medical oncologist who works at the Kettering Cancer Center. I see patients at Long Island locations both at Unionville in Nassau County and in Sloan in Suffolk County. And today I'll be focusing on the evolving landscape of HPV-related head and neck. Okay, so here's just a brief outline of what I'll be talking about for the next 30 minutes or so. I'm just going to give a brief overview of head and neck cancer, including what it is, risk factors, signs and symptoms, and treatment options. And then I'll discuss what preventative measures we can take to reduce chances of developing head and neck cancer and improving outcomes. And lastly, I want to discuss HPV-related head and neck cancer, as well as some of the unique trials that Memorial Sloan Kettering is offering for these patients. I have no financial conflicts of interest in that. So to start my talk, I thought I'd just give you guys some background about my own journey to becoming an oncologist. I always think it's important to look back at our own walks and act as a good reminder for me of my own motivations and to sort of just honor the people that pushed me to where I am. Okay, so this handsome child is me back in 2001, enjoying myself on a Christmas morning. But this was also the year that my father was diagnosed with head and neck cancer. So I was in middle school at the time, and as you can imagine, watching him go through chemotherapy and radiation left a very, very big impact on me. And seeing what he had to go through really changed me and kickstarted my desire to become a doctor. Now, fast forward to 2012, this is when I started my medical school training. This is me and my parents celebrating my white coat ceremony. This was a very big moment for me, just to be able to celebrate with my father. Really the main reason I went into medicine. And from medical school, I don't think I really expected to end up as an oncologist, but life kind of has a funny way of using your past experiences to shape and guide your future path. So as I went into residency at Mount Sinai and a fellowship at Hopkins, I somehow ended up as a oncologist, treating the same cancers that my father actually had. And fast forward even more to 2024, this past Father's Day, and I can't believe it's been over 20 years at this point since his diagnosis, but it still feels so recent to me. So for me, looking back, it always humbles me because the start of my journey is really my father's own experience with head and neck cancer. And I wanted just to take some time to share that this is a lot more than just a job to me or a career, but really an opportunity to connect with my patients and walk alongside them during some of the hardest moments in their life. Okay, so on that note, I want to just take some time talking about head and neck cancer. So let's go some background to put things in perspective. Head and neck cancer is the sixth most common cancer that's diagnosed worldwide, behind things like lung cancer, breast, prostate, colon cancer. There's about 900,000 cases annually worldwide, and about 70,000 in the US each year. This is felt to increase to over 1 million by the end of 2020, so it's beginning in 2030. They're predominantly occurring in men, about 2 to 4 times more common, and there's a lot of different types of head and neck cancer. Today, I kind of just want to focus on the squamous cell carcinomas. These are squamous cell cancers that develop in the mucosal epithelium, and these are generally classified by anatomy. So on the right, you can see a simplified model of head and neck cancer regions. So cancers can originate from the nasal cavity or paranasal sinus down to the oral cavity, then down to the pharynx, which is sort of split into multiple regions, the nasopharynx, oropharynx, and hypopharynx, and then also the larynx. And just to emphasize how global of a disease this is a figure pulled from a publication from Nature a few years ago. just showing the age standardized rates of head and neck cancer incidence worldwide for both men and women. It's predominantly a cancer in North America, Europe, and in Asia, as you can see by sort of the darker blue regions. Now, multiple studies have revealed like a diverse range of risk factors for head and neck cancer. Some of them are more well known, some of the other ones are kind of emerging. One of the biggest risk factors is carcinogen exposure to alcohol, tobacco, or betel nut use. Heavy users of tobacco and alcohol have a over 35-fold higher risk of developing head and neck cancer. More commonly among Asian populations is the use of betel nut. These products are linked to very high rates of oral cavity cancer. This is mainly in areas such as India, Taiwan, and China, where betel nut products are commonly used. In general, the high male predominance of head and neck cancer probably reflects like the sex-specific patterns of these risk factors, such as tobacco and alcohol use. And more recently, we have these like electronic cigarettes and vaping, and I think data is sort of unknown right now how that's going to affect head and neck cancer incidence, but in the next coming decades, I think we'll come to know that probably will be a new risk factor. Another risk factor of head and neck cancers, I'm sure as well aware, is viral infections, mainly EBV, Epstein-Barr virus, or HPV, human papillomavirus. These are heavily associated with the development of cancers in the nasopharynx, the salivary gland, and the oropharynx. Next, we have occupational exposures to pollutants such as exposure to wood dust has been associated with the development of nasopharyngeal cancer, and then jobs in construction, metal, textiles, ceramics, that's associated with increased risk of larynx cancer. Genetic factors and immunodeficiency can also contribute to head and neck cancer risk. For example, individuals with Fanconi's anemia, which is a very rare inherited genomic disorder that impairs DNA. These patients have a 500 to 700-fold increased risk of developing head and neck cancer. That's primarily the oral cavity. And then immunodeficiencies have higher incidences of cancer across the board, head and neck cancer is included. Lastly, there's some emerging evidence that poor oral hygiene or diet lacking in fruits and vegetables can also contribute to someone's individual risk of developing head and neck cancer. This is maybe through changes in the oral microbiome or periodontal. So we have fruit today for lunch, so please eat more fruit. This is just from a recent publication in JAMA, came out of NYU, looking at the oral microbiome and the risk of head and neck cancer development. We looked at over 200 cases of head and neck cancer, and I think there were 13 oral bacterial species that they found associated with head and neck cancer risk, as well as perioral disease. Next, I want to just talk about the common signs and symptoms of head and neck cancer, which are all kind of expected due to their anatomic locations. Usually, many other cancers, sometimes very hard to diagnose early, so we have multiple screening mechanisms to catch cancers. With head and neck cancers, the symptoms tend to be identified kind of early on, mostly because of where they're located. So many of these are discovered at earlier stages where curative and therapies are still possible. So we might see our persistent mouth sores or white and red patches in someone's mouth. That could be a sign of oral cavity cancer. Very common presentation we see these days is someone comes in with a lump on their neck that's persisted despite a course of antibiotics or maybe a course of steroids. This is usually a painless lump, and this can be a sign of multiple different cancers: oropharyngeal cancer, thyroid, salivary gland cancer. Head and neck cancers can sometimes also present with pain, though, so people can have throat pain, difficulty swallowing or painful swallowing, and sometimes even changes in their voice. Global symptoms such as unexplained weight loss, fatigue are pretty common as well. That's really a common sign across malignancies across the board. And then sometimes you also have some ear pain or muffled hearing if there's eustachian tube dysfunction from, let's say, an oropharyngeal cancer. And lastly, cranial nerve palsies or sinus congestion and epistaxis can be a sign of a nasopharyngeal mass. So what I tell people is, if you have patients who have these signs and they persist despite a couple of weeks, maybe some early interventions like steroids and antibiotics, these definitely warrant an ENT evaluation so they can do a thorough scope exam. So, unfortunately, like other cancers, there's no real strong evidence that comes in screening in the United States for head and neck cancer. And like I said, it tends to be caught kind of early because of its location. People don't usually let lumps in the throat go on many, many months before seeing someone for further evaluation. But I do recommend annual examinations with primary care doctors and dentists to look for lymphadenopathy, oral masses, or ulcers. And educating our patients is still key though in reducing common risk factors for developing head and neck cancer. So encouraging smoking cessation is very important, drinking alcohol moderation. Head and neck cancer is actually one of the few cancers where there is a vaccination that can help prevent the development of cancer, and that's the HPV vaccine, the human papilloma virus. So the majority of oropharyngeal cancers are associated with HPV at this point. And thankfully, there is a vaccine that prevents more than 90% of cancers caused by HPV. The CDC recommends it for children starting 11 or 12 years old. I mean, I think it goes even as early as 9, to be honest. And really, it has the most benefit for patients under the age of 26, although you can get it all the way up to the age of 45. And I think it's a 3-part series vaccine. There are over 13 million people per year who get infected with HPV, so the vaccine is very important. It protects against 9 of the high-risk strains of HPV. Other things that are important are just wearing a mask if you are exposed to toxic fumes in your career, your job, and then having routine examinations, a well-balanced diet, and maintaining good oral hygiene. Okay. The treatment of head and neck cancer follows a pretty similar schema to most other cancers. The early stage single modality treatment is oftentimes sufficient. Either surgery or radiation alone can be enough. The majority of cancers, however, majority of patients present with more advanced cancers, usually because it's involved the lymph nodes at that point. For these, there's usually some combination of surgery and radiation, or chemotherapy and radiation, or chemotherapy and surgery. These are usually just divided into resectable or unresectable diseases. So this really requires a multidisciplinary discussion to make sure that head and neck cancer patients are ensuring the appropriate personalized treatment plan. And then unfortunately, if it reaches the metastatic setting when something is unresectable, that also changes our treatments to more palliative intent. That includes things like chemotherapy, immunotherapy, and targeted therapy. Okay. So now I want to shift gears and just talk about HPV and the key role it plays in head and neck cancer, both in its pathogenesis and treatment. So a large portion of what we see here in the United States these days is oropharyngeal cancer. So basically, your cancer originating from where your tongue and the back of your throat meet, and the majority of these are driven by HPV. So HPV is a double-stranded DNA virus with over 200 strains. There are about a dozen high-risk strains that can cause cancer. The one in head and neck cancer that's predominant is HPV-16. Another cancer that HPV is known to be associated with is cervical cancer. That one predominantly is from HPV-18. Mucosal HPV is responsible for a wide spectrum of diseases, ranging from things like warts to invasive cancers of the oropharynx, cervical cancer, or anal cancer. The majority of cases involve the viral DNA integrating into the host DNA, but that's not always the case. Over 80% of Americans have had an HPV infection by their mid-40s. Luckily, most of these are asymptomatic and they resolve without intervention, but in a few people, the virus can persist and cause cancer. Now, there is an increasing rate of HPV-related head and neck cancers, as you can see from this graph. The graph on the left represents the incidence trends for oropharynx cancer in the United States, that's stratified by race and sex. Graph A on the left is for men, graph B is for women, so you can see there's a pretty striking difference between men and women predominance for head and neck cancer. But really, there's this dramatic rise in head and neck cancer across almost all the racial groups, mostly due to the prevalence of HPV. This, I would say, like within the past decade or so, things have kind of changed in our thought process on this, and that it used to be largely thought of as like a Western or Caucasian disease. But the two graphs on the right represent, on the top from Taiwan and the bottom from South Korea, showing an increasing incidence over the past 2 decades of HPV-related head and neck cancer. So this kind of is really a global thing that everyone has to be aware of, whether you're involved in cancer, primary care, dentistry, or anything else. Now, really, the canonical pathway of how HPV infections can result in cancer is through the viral oncoprotein E6 and E7. So E6 leads to degradation of tumor suppressor P53, E7 leads to degradation of tumor suppressor RB. And there's a lot of other pathways that these oncoproteins can contribute to cancer progression, things like interacting with DNA repair, like BRCA or BARD, for example. The figure on the right shows an example of, here, here's an example of just what a normal tonsil looks like, this normal tonsillar crypt. And along the basement membrane, there are these epithelial cells, and these cells sort of differentiate, they slough upwards until they're terminally differentiated as they detach from the basement membrane, and they just sort of slough off. There's also this unique reticulated squamous epithelium that lines the crypts and the gaps, and causes these sort of fissures along the tonsil. This allows your immune system of lymphocytes to enter the crypts, and this interacts with external antigens or foreign bodies. So this is how a normal tonsil is really supposed to function and contribute to your sort of immunosurveillance system. When someone gets an HPV infection, though, this disrupts the gaps, and the virus can access sort of those basal stem cells along the basement membrane. Immune cells also get in touch with the HPV. And in some cases, the viral genes are then induced or activated, leading to production and shedding of the new viral particles. Now, the stem cells down here likely represent the origin for HPV head and neck cancer. And when the viral genome integrates into the host genome, it starts making E6 and E7, and these are the oncoproteins, like I mentioned before, that promote malignant transformation. Okay. This is just in comparison to HPV negative head and neck cancers, where exposure to carcinogens is the main driving force for the pathogenesis. So a variety of risk factors, like we talked about, tobacco, alcohol, betel nut use, pollution, these things can lead to carcinogenic exposure. These then can become metabolically activated and lead to DNA damage. If the DNA damage is repaired accurately, there's hopefully no lasting consequences, but if the damaged DNA is not properly repaired or isn't repaired properly, that damage can form into mutations, deletions, and amplifications, and depending on which genes get impacted, that can affect key tumor suppressor genes or signaling pathways that then lead to the development of head and neck cancer. So as you see, there are two very different types of cancers based on the pathogenesis. This is just a chart to further emphasize the differences between HPV positive and HPV negative head and neck cancer. We talked about how the pathogenesis is different, just they are very different genomically as well. This is a figure from the TCGA looking at different differences in genetic alterations between the two types of cancers. On the left is HPV negative cancers, on the right is HPV positive cancers, a relatively small number here. This is almost a decade ago at this point. And there's over 200 HPV negative cancers. As you can see, there's quite a stark split between the different mutations that are commonly associated between these cancers. For example, you can see here the P53 mutations are very uncommon in HPV positive cancers. Not very surprising because we understand how E6 oncoprotein can result in degradation of P53, while in HPV negative cancers, you can see it's a lot more common and this gets mutated. There's also a higher incidence of PIK3CA mutations in HPV positive cancers at 56% compared to a 30-something% here. This is just another graphical representation of the different genomic profiles. The top half shows HPV positive cancers, the bottom half shows HPV negative oropharyngeal cancers. And you can see these are just the top mutations that are identified in the genome for HPV positive disease, mostly in PIK3CA, you have FGFR3. Down here, though, is mostly these tumor suppressor genes with TP53, Notch, CDKN2A, and FAT1. So not only are they different pathogenically, they're different genomically, they're also very different clinically as well. So starting just with the clinical presentation, patients with HPV positive disease are usually, they can be at all ages, younger and older, while HPV negative disease tends to be presented mostly in our older population. HPV negative disease also generally presents with a large primary tumor, so they typically have bulky primary tumor causing difficulty swallowing or difficulty speaking, where HPV positive disease typically has a very small primary tumor. Sometimes you can't even find it at all. And really they come with these bulky lymph nodes because there's very early lymph node involvement if it's an HPV-related head and neck cancer. As we talked about, HPV negative disease is often associated with heavy tobacco use and usually minimal or no tobacco use for an HPV positive head and neck cancer. HPV also generally affects the oropharynx or the tonsil or the base of the tongue region, where an HPV negative cancer can have multiple sites. And most importantly, in HPV positive cancer is a very good clinical prognosis, where an HPV negative cancer tends to have a worse prognosis. As you see here, this is one of the earliest studies from 2010 that really was able to characterize the difference in survival rates between HPV positive and HPV negative disease. As you can see up here with HPV positive disease, we're looking at like a 2-year overall survival of like 90+%, while for HPV negative disease, it's probably closer to around the 60% range or so. So a pretty stark difference between the two of them. This big difference in the high rates of cure for HPV positive cancer has led to this idea of de-intensification. This is an emerging treatment approach for HPV positive head and neck cancers, specifically for oral pharyngeal cancers. So that's cancers coming from the tonsil or the back of the tongue. And these are aimed to try to reduce someone's toxicity to treatment while still preserving sort of the superior oncologic outcomes. Now, there's many ways that the field has been trying to address de-intensifying therapy for someone's treatment. This is just a very rough schema of the different approaches that have been taking place. You know, some patients can undergo primary surgical resections, and then based on the pathologic risk factors, they can de-escalate adjuvant therapy. So maybe you might omit chemotherapy from some patients, so you reduce exposure to that, or maybe instead of getting 6 weeks of radiation, patients will only get 4 weeks of radiation, which also decreases acute and late toxicities from radiation. Other groups have looked at clinical risk stratification, so sort of taking patients up front, assessing the size of the tumor, nodal involvement, maybe imaging techniques, and clinical history like smoking exposure, for example, and then de-escalating patients to maybe less chemotherapy or less radiation. And lastly, there's a group looking at induction chemotherapy and immunotherapy, trying to shrink the tumor with chemo and immunotherapy first, then using someone's response to de-escalate therapy. If it shrinks a lot with chemotherapy and immunotherapy first, maybe these patients can get less definitive radiation or surgical treatment. Next, I want to highlight sort of some of the unique approaches that we're doing at Memorial Sloan Kettering. This is a study that was done, published just earlier this year, titled Hypoxia-Directed Treatment of Human Papillomavirus-Related Oral Pharyngeal Carcinoma. You know, there's very significant evidence, particularly in head and neck cancer, that hypoxic tumors are resistant to radiation. This is true for both HPV positive and HPV negative disease. This is felt to be because the reduced radiation-induced free radical production from a hypoxic environment leads to more aggressive tumors. So the hypothesis was that that the aerobic state of a tumor could potentially identify which patients would be eligible for de-escalated chemoradiotherapy while maintaining treatment efficacy. So we utilize a PET scan that uses a hypoxia-specific tracer to try to stratify patients between reduced radiation at 3 weeks of radiation versus the standard, which is 7 weeks of radiation. 3 weeks of radiation, or 30 gray, is really the lowest that has ever been clinically studied. Less than half of what's traditionally given, which is the 70 gray of radiation, and would be the lowest reported dose of radiation given concurrent with chemotherapy. So between 2017 and 2020, we enrolled 158 patients with HPV positive disease. It's pretty small here, but you can see that it's right there. Patients underwent resection of their primary tumor, and they were eligible for this study whether they had positive margins or not. They also received a baseline hypoxia PET scan. The patients where tumors were thought to be hypoxia negative, meaning they might have a good prognosis, went on to receive de-escalated radiation with chemotherapy at 3 weeks of radiation at 30 gray. So that's right here, this red part, baseline negative. There was ended up being 28% of patients had a baseline negative hypoxia scan, and they just got 3 weeks of radiation and 2 doses of chemotherapy. For patients that had a hypoxia positive scan, patients underwent 1 week of chemotherapy and radiation, and then they got a repeat hypoxia scan to see if just starting therapy or a single dose of chemo could sort of induce a hypoxic negative tumor microenvironment to evaluate their initial response. If the tumor became hypoxia negative, those patients would then also go on to receive another dose of chemotherapy and only complete 3 weeks of radiation. Patients with persistently positive hypoxia scans would receive a standard of care 70 gray of chemotherapy and radiation. So as I mentioned, 28% of patients in the beginning had a baseline hypoxia negative scan. They went on just to receive the 3 weeks, while the other 72% got 1 week of treatment, and about 80% of those ended up getting de-escalated down to 3 weeks. So they had an initial response. So overall, 85% of patients on the study received 30 gray, while 16% received the 70 gray, which was the standard. This led to a 2-year local regional control rate of 95%, which is excellent. The 2-year progression-free survival and overall survival for the entire group was 94 and 99%. So sort of as we expect traditionally from a HPV-positive head and neck cancer. For the 30 gray cohort, so for the patients who only got 3 weeks of chemotherapy radiation, the 2-year progression-free survival was 94% and 100% overall survival. For the 7-week cohort, the PFS was 96% and the overall survival was also 96%, as you see here. I believe red is the de-escalated and then blue is the standard of care treatment. So a total of 8 patients had recurrences in their lymph nodes, but all of them went on to have successful surgical resections afterwards. I don't have it updated on this slide here, but from an acute toxicity perspective, as you can expect, getting 3 weeks of radiation, there's significantly less mucositis, less dysphagia, less dermatitis, less taste changes. We still are waiting to see the long-term quality of life improvements from this study because this was just published this year. But clearly, for certain groups of patients, 3 weeks of chemotherapy radiation may certainly be enough. Now, this has led to a phase 3 randomized study now, which is open and enrolling at Memorial Sloan Kettering. This is a double-blind phase 3 trial randomizing patients to either 30 gray, 3 weeks, or 7 weeks, 70 gray of chemotherapy radiation based on a hypoxia PET scan. So we're very excited for this to finish enrollment so we can hopefully see this becoming a new standard of care in the future. The next trial I want to highlight is another sort of unique approach that we have here at Memorial Sloan Kettering, looking at patients with HPV-positive head and neck cancer, but sort of in the minimal residual disease setting. So this is a trial looking at, that's a viral vector-based therapy, HB202, HB201, in patients with HPV-positive head and neck cancer, looking at it in an adjuvant setting. So just as some background, cell-free DNA was first described back in the 1940s. These are fragments of DNA, extracellular DNA that's found in the blood, in the saliva, other bodily fluids. In healthy individuals, you'll find cell-free DNA detected at varying amounts, though usually at very low levels. Tumors, though, can release cell-free DNA through apoptosis, necrosis, phagocytosis, and the fraction of cell-free DNA that comes from tumor cells is then termed circulating tumor DNA. And now the ability to detect ctDNA has improved dramatically over the past few decades, from real-time PCR to digital PCR to next-generation sequencing, and now many of these are commercially available. There's actually some sponsors that are here. This has opened significant opportunity on how to incorporate these tests into our practice. So there's been multiple studies looking at how circulating HPV DNA correlates to tumor burden, correlates to treatment response, and now in this trial we're looking to use it in a minimal residual disease setting and use that information to actually make treatment decisions. So here on the right is just a graphical representation of a hypothetical patient who's getting chemotherapy and radiation for an HPV-related head and neck cancer. And this is just sort of the hypothetical changes that you'll see in someone's ctDNA over time across the treatment. The dotted blue lines here represent the minimal residual disease detection limit. Once again, this is all hypothetical, and this is also the threshold for clinically apparent disease, meaning it has to be at a high enough level where you can detect it in the blood, but you might actually notice someone having a lump on their neck or a mass in their throat. One of the limits here is, the MRD detection limit can be improved more. Circulating tumor DNA for HPV could even be used as screening tests. But right now, I think that's still a few years away in terms of the sensitivity. But during treatment, as you can see here, generally when someone undergoes chemotherapy and radiation, you will have an increase in someone's HPV ctDNA, usually for the first 2 weeks until they reach a peak. And then 95% of patients will actually clear their ctDNA by 4 weeks, which would indicate a very optimistic treatment response. Then low levels can persist afterwards, and low levels have been linked to early treatment, recurrence, sorry. So this trial really leverages our understanding of HPV ctDNA dynamics. So to be eligible for this trial, patients have to have definitive treatment for their head and neck cancer, whether it's surgery or chemotherapy radiation. And what we would do is we would enroll them in a monitoring phase on this trial. So they get blood drawn every 3 months or so, and we try to detect HPV in someone's blood. If they are found to have HPV in the blood and they have no evidence of clinical or radiographic disease, meaning only its minimal residual disease is not clinically or grossly apparent, they're eligible to proceed into the actual intervention part of the study, where patients are then randomized on 2-to-1 basis to either placebo or this IV intervention, which once again is like a viral vector-based therapy. It has an E6 and E7 oncoprotein that sort of is built into an arenavirus, and that's meant to promote T cell activation and proliferation against the disease. That's pretty good activity in single agent therapy, monotherapy, in the recurrent metastatic setting, so this is the first time we're looking at it in the adjuvant setting. So just in summary, I think the time's coming up. Head and neck cancer is very common, the 6th most common globally, and there's increasing incidence worldwide. This is largely driven by the presence of HPV or human papillomavirus. We should all be encouraging patients to, in preventative measures for patients, smoking cessation, reducing alcohol intake, HPV vaccination, routine examinations, and good oral hygiene. HPV positive head and neck cancer is very distinct from HPV negative cancer, pathogenically, genomically, clinically. Most of them occurring in younger patients and have an improved prognosis. Efforts are being made to de-escalate therapies. It can be as low as 30 gray of chemotherapy and radiation for tumors who demonstrate hypoxia. And HPV circulating tumor DNA is now commercially available, and we're evaluating its use in the minimal residual disease setting to make treatment decisions and improve outcomes. And that's it. Thank you, everyone.
All right, thank you, Dr. Hwang, for your wonderful talk. Thank you so much. And also, I want to thank Memorial Sloan Kettering Center for joining us today. Thank you. Hopefully to see you soon again. Yeah. And we are going to take a break. I have a question. How do you feel about the temperature? Do you feel cold, or is it okay? Or shall we increase the temperature a little bit, or we're fine?